Hello, my name is Michelle Lum and I'm the Respiratory Care Director here at Jameson Hospital, and the purpose of this class today is to review basic pulse oximetry as well as oxygen principles in relation to our hospital-wide policies and procedures. How many times have you walked into a patient room and you found them short of breath? Probably happens every single day, but it's how you respond that will make a difference in patient outcomes. As I previously stated, it's a basic review of oxygen equipment and oximetry, and this will help you be more comfortable with reporting your results to nursing as well as caring for those patients that are on critically high levels of oxygen. We first review pulse oximetry, indications, applications, and erroneous readings, followed by the oxygen devices with some troubleshooting and safety. Pulse oximetry is indicated for monitoring of oxygenation and can provide early warning signs for hypoxemia. I'll be citing an abstract from Gibran in a Critical Care magazine from 2015, as well as the hospital-wide and respiratory care policies and procedures for this presentation. Correct application of pulse oximetry is very important. We tell patients, our staff, to actually use the non-dominant hand, because if you use your dominant hand, you get a lot of artifact. Usually have the best pulse as well in your middle finger. So once you apply the oximeter, we want to make sure that we're waiting at least 15 to 30 seconds so that we can have an accurate reading. Far too often we see staff put the probe on the finger and then they take the first reading they see, but we would like the reading to stabilize. You can also look at the waveform. If you have a big table-side pulse oximeter, you can look at the waveform graphics or the pulsatile signal on the small oximeters as well. If you're ever in question if the reading is valid or not, you'll want to take an apical or a radial pulse, and then you'll correlate that with the heart rate that's on the pulse oximeter. So those things are very important. You also want to make sure that you avoid hands that are edematous or possibly cold, or if the patient has low blood pressure, poor perfusion, you would want to use possibly an earlobe for the reading. Other things that can affect a reading are excessive ambient light, as well as artificial nails and dark nail polish. So you'd want to avoid those areas as well, or make adjustments accordingly. As far as critical value reporting, less than 89% in an adult we would call a medical response, and less than 93% in a child. We usually titrate and keep patients on oxygen and like their saturations to be above 92%, and for the pediatric population would be above 95% prior to titrating. All of the documentation is done in our Siemens Net Access, and you can find the latest pulse oximetry readings as well as the protocol and orders for the titration range within Siemens Net Access. Many times patients with COPD will have a lower than physician-specified range, such as 88 to 92, rather than the hospital-wide policy of 92% for adults. So moving on to oxygen therapy, we're going to look at some basic oxygen equipment. We'll start out first with your nasal cannula. Nasal cannula flows 1 to 6 liters. After 4 liters, we would want to humidify the oxygen. It can be very dry. If in fact the patient has bleeding or dry nares, any patient complaints, we can humidify at any level, though our policy does state after 4 liters we would humidify. Once the patient has needs greater than 6 liters, we may need to look at a different device, because on your basic nasal cannula you cannot go higher than 6. So at that point we may look at a Venturi mask. This type of device actually entrains room air, and it mixes with the amount of liter flow that we have bled in to give the desired FiO2. For these patients, the set liter flow will tell you the desired FiO2 that you'd want to achieve. So for example, this system goes from 24 to 50% based on the different adapters that we have. We would set that up and then set your flow accordingly. This is the only type of mask that you would actually use a lower flow. Most masks require 5 to 6 liters to flush out your exhaled CO2. So we don't want retention under the mask, so therefore we'd want to ensure that this is the only mask that has that exception. So This mask is typically used for COPD patients. Once you've passed that 50% range and the patient is becoming a little more unstable, you want to go to either a high flow cannula or short of a non-rebreather, which will give you 100%. So the first high flow system is the high flow nasal cannula, and as you can see, it does look a little different from our basic cannula, and the coloring is green. This type of cannula is always humidified with a special humidifier that has a pop-off valve so it can ensure adequate flow. 6 to 15 liters is the flow for this type of cannula. The material is pretty pliable, so it's soft and comfortable for the patient to wear. The only disadvantage with this type of cannula is for transport. Because it requires humidity, you cannot connect this to our oxygen cylinders for transport. So at that point, you'd want to contact someone from respiratory therapy, and they can change the device type to either a non-rebreather or a oxymizer. Next type of high flow system is the oxymizer, and as you can see, this type of system has larger pillars for the nares, so sometimes it's not as easily tolerated. The tubing's pretty bulky, but it does have an oxygen pendant here. This type never is humidified because unfortunately, if the diaphragm in here would get wet, there's a little membrane, then it wouldn't function, and it could actually cause obstruction for the patient. The patient wouldn't get any flow at all. So very important, even though it's high flow, this particular device does not require humidity. And 6 to 15 liters as well, and you can transport patients on this type of device. Last, short of someone requiring either intubation or non-invasive ventilation in an emergent situation such as a medical response, the nurse may ask you to get a non-rebreather. So as you're retrieving from the Omnicell, you're going to want to look for the device that has the oxygen attached bag. With this bag, we want to make sure that we have adequate flow going to the bag. So when it's connected to an oxygen source, the bag fills completely up. If it's overinflated, then you have too much flow. Likewise, if it's flat like this, you have no flow or not enough flow. What you want to achieve is when the patient takes a breath in, that the bag collapses halfway down and then refills as the patient exhales. As I said before, this gives you about 100% oxygen, so it is for the more critically ill patient. You do not want to be leaving patients on high flow oxygens or as well 100%, because it actually can cause nitrogen washout in the alveoli and some O2 toxicity and refractory hypoxemia. So therefore, our goal for oxygen therapy is to provide the lowest amount of FiO2 to get the highest saturation possible. Aside from our basic oxygen therapy, there are some safety considerations to be knowledgeable about. And basically, not so much in the home healthcare setting here in the hospital, but at home, patients that are going to go home on oxygen, we have to make sure that they're well educated regarding not cooking, not being exposed to any flames, any smoking, any sparks with electric devices or razors. And one of the other things that I had, there's a good safety tip from the American Lung Association, and that's actually no Vaseline products, anything petroleum-based, because they are also combustible. So therefore, you do not want to have your patients using those types of products. If anything, it should be water-based. So in conclusion, we've reviewed with you why it's important to understand basic pulse oximetry as well as the oxygen principles and how it applies to our policies here at Jameson. And the next time you're in a room with a patient and they become short of breath, you'll be able to respond appropriately and relay accurate pulse oximetry findings. I appreciate your attention to this presentation, and if you have any questions, we can review with you when we're finished. Thank you.
I have a question.